All right, all right, all right. Good morning. Good If you guys have a seat next to you, we have some folks in the back that are looking for seats. Please just let them know. We're all family here. We can get nice and close with each other. All for health equity. Okay, so we are going to get started. My name is Vacheria Keres. I'm the Associate Vice President of Policy and Regulatory Affairs at the National Association of Community Health Centers. It is truly my pleasure to be here and welcome you all to the second CMS Health Equity Conference. This session is outreach and engagement, replicable strategies to reduce disparities. I think we all are familiar here with the valuable work that folks do in the outreach space, in the enrollment space, and really being connectors in their communities and making sure folks are aware of the services that are available to them, but also helping them get to those services. That we know it's not just the education. Sometimes people need help along the way to really connect to not just the healthcare services they need, but all the life services, right, that really improve health outcomes and maintain those outcomes. I represent community health centers where that's their work every day. Their bread and butter is doing outreach and enrollment work, connecting patients to services that address social drivers of health. And today, our presenters have three different perspectives on outreach for different communities, vulnerable communities, aging community, the Indian community. And so it's really important that we think about these different perspectives because it's also not a one-size-fits-all approach for every community and their needs and how to get there. So really excited for our presenters today. They're going to give their introductions, but wanted to say we have Covering Wisconsin, we have Virginia Agency on Aging, and then we have Keres Consulting. So first, we're going to kick it off with Covering Wisconsin. Thank you, guys. And we'll do Q&A at the end.
Looks like we're having some fun with this TV. Good morning, everyone. Thanks so much. Yay, it's nice when people say it back. It's so great to be here. Thank you for having us. I am one of your presenters today for Mini Grants Big Impact, an outreach strategy to reduce health coverage disparities and raise awareness about health insurance resources, which is an overview of our Community Mobilizer Mini Grant program. My name's Marshalek. I'm the Community Relations Coordinator for Covering Wisconsin, and my colleague Cheryl Isabell is also here, and you'll hear from her in just a bit. She's our Milwaukee Community Engagement Lead. We both work for Covering Wisconsin, which is Wisconsin's health insurance navigator agency. We assist consumers with both Medicaid and Marketplace, and in addition to our direct service, we also create and provide support with health insurance literacy materials. We are also a program of the University of Wisconsin-Madison Division of Extension. Our Community Mobilizers Mini Grant Program was created in June 2022 to raise awareness about health insurance assistance and resources throughout Wisconsin communities. Mobilizers are awarded up to $4,900 per fiscal year to offset their outreach costs to help raise awareness about health insurance assistance and resources in their communities. Covering Wisconsin equips these mobilizers with professional training, as well as outreach and educational materials about health insurance trends and resources, which includes things like the Medicaid unwinding and what consumers need to know about Medicaid redeterminations. Mobilizers submit a brief grant proposal and grant report at the start and end of the grant period. And it is brief because it is a mini grant, and we want to minimize the administrative burden on these community organizations. It's really just to support outreach costs that they are already doing, rather than creating any kind of a big new project or undertaking. Since the program's inception, 36 mini grants have supported 26 community-based organizations in 2 fiscal years. What is a mobilizer? A mobilizer is a trusted community partner who helps spread the word about important health insurance topics in their community, but does not provide direct enrollment assistance. Rather, they support and referrals to enrollment assisters for consumers. And the ideal mobilizer is already active and trusted in their communities. They exist in these kind of outreach hubs, or they are already going out into the community and are a resource to traditionally underserved communities or other priority populations, and or are well positioned to meet consumers where they are, or they happen to be in some type of location where consumers happen to naturally come to them or are at home with them. This is ultimately a strategy for reducing health coverage disparities and health disparities. As we all probably know, to reduce health disparities, people need access to affordable health coverage. So, in addressing health coverage disparities, we address health disparities. We do this by leveraging organizations who are active and trusted within communities that have higher uninsured rates than the general population and who are most at risk of losing Medicaid during the unwinding, or were most at risk of losing Medicaid during the unwinding, and or who experience unique barriers to accessing healthcare coverage. This includes groups like low-income Wisconsinites who are uninsured at twice the general state population's rate in Wisconsin, and many communities of color, such as the Latina population in Wisconsin is uninsured at 3 times the statewide rate. This is partly due to language barriers and complex immigrant eligibility rules and fear often surrounding public charge rules. I will welcome my colleague Cheryl.
Thank you, Tina. Good morning, everybody, and thanks again for having us in Wisconsin at this conference to speak with you about our mini grant mobilizer program. So Tina covered a lot about the framework of the mobilizer program, the strategies of it. And now I'm going to talk a little bit about why mobilizers. Why do we use mobilizers to help in our works and efforts in doing outreach to our most vulnerable communities? Mobilize are more effective to work through organizations already on the ground. So in other words, these are organizations that are in our rural and urban communities that communities are familiar with. So they're community-based organizations. They've already built and earned the trust of their communities and folks in those communities. So they already know the familiarity of the mobilizers in that area. So they are best to reach population that we want to serve and provide information to. Our mobilizers also, they fit the capacity of the navigators who are mostly on the phones up with people with enrollment and answer questions that they have about their health insurance coverages or just general questions about health insurance because it's complicated. So they help us with the outreach or help with that capacity of outreach where we normally have to be in those communities, and they're able to reach those populations that we're unable to reach because of the other duties that we have to perform as navigators. Mobilizers also feedback. They help improve our outreach toolkit. They they provide information from community members that are telling them what they need to see. So that in turn helps cover Wisconsin, as Tina mentioned. We create a lot of health insurance literacy material for the community to be able to better manage their health care that they have and understand all those intricacies of maximizing and utilizing health insurance coverages. So they are helping us with the terminology that needs to be understood by people that are actually using those services, and they're best to tell us that they need to see in plain language. So community reach, like Tina said, 19 of our 26 mobilizers provided language assistance. So not only are they getting those extra flyers and things in the communities that we want our consumers to be able to have, they're reaching those language proficient or people that need with language proficiency, and they're in those neighborhoods, they're in those communities, and they help. And a lot of our mobilizers are available they speak Spanish, Hmong, Burmese, Karen, Karenni, and Swahili. So they're able to translate that information that we're trying to get into the community to those people that live there so that they understand in their own language how to access and have access to health insurance and health care. All 26 mobilizers supported low-income communities. So yes, we are looking and targeting those zip code areas in all 72 counties of Wisconsin, which are the most vulnerable, which are more likely to have a lower income, which are more likely to be uninsured or underinsured, or more likely to have Medicaid, Medicare Plus insurance programs or beneficiaries. And at least 22 of our 26 mobilizers supported cultural, ethnic, or racial groups. And that's working a lot through the refugee communities as well. So our mobilizers in Wisconsin are very creative. So not only do they go out and they do grassroots efforts to get this community information out on health insurance coverages and during the Medicaid redetermination, how to keep your contact information fresh and updated so that they will receive the necessary letters on when their redetermination dates are. They actually provided at least 300 for consumer referrals. They sent out to over 13,000, almost 13,000 text messages. They made 197 phone calls, 4,200 one-on-one conversations, sent email blasts. They had podcasts. And like I said, they hold focus groups for us. And throughout this whole redetermination and renewal process, and because they trust Covering Wisconsin, like Tina says, we trained them to further go out and do this work. They are continuing to promote Covering Wisconsin, sending referrals to us, folks that we help for free find the necessary health insurance coverages that they need. So with that, I will turn it back over to Chino. Thank you.
One last note I'll make on the impact. You'll notice the timeline was July 2022 to June 2023. So these numbers are only from one fiscal year because they haven't submitted their grant reports yet for this fiscal year. So in one fiscal year, we had at least 304 consumers referred from the mini grants in that year. And there have been 26 community-based organizations this fiscal year and last fiscal year combined. So I think that it speaks for itself. For those who may be interested in replicating this program, I do have some tips or logistics to consider when you're doing that, at least based on what we've experienced so far. The first is to launch the program, identify the community organizations in your area that are already trusted and active within their communities, because these will be the hubs that people are already connected to, and they can simply integrate something as simple as adding a question to their intake process of, do you have health insurance? And then discover who does and doesn't and know when to refer them to an enrollment assister. Also, when you're doing this search process, if you're needing something specific, like you know that language assistance is needed, you can intentionally seek out organizations that speak those languages and are comfortable and willing to have these conversations with people about whether they have health insurance or whatever your topic is. I would also say to design a simple application and reporting process. I mentioned this earlier, but it's pretty intuitive. Nobody wants to spend a significant amount of time on a mini grant. You're just not going to get the applications that you want, and that means you're not reaching the people and the organizations you want to. So I would keep it as brief as you can while still ensuring that you're getting the information you need to make the best decision on who to give the mini grants to. And for the reporting process, just keep it a couple rows, like give me a couple metrics. If you attended events, let me know how many events you did. If you want to give me a narrative, feel free. Enough that you know how the program went, but not so much that they are having to write a huge report. I would also say to ensure an accessible payment system to the best of your ability. Many of these organizations may be smaller organizations. They may need the funding to do the work, even though it is a small grant. And if you happen to be part of a larger institution, there may be a lot of paperwork involved with these sort of things. So I would just try to minimize that as best as you can and offer as much support as you can to get people paid. Also, plan to offer some technical assistance and training. We already mentioned like the health insurance training, knowing what the Medicaid unwinding is, knowing what kinds of questions to ask people. But I would also plan on offering some technical assistance for grant tracking and grant reporting, because just different community leaders may or may not have that kind of training and may want some support to submit a good grant proposal. Thank you. Sometimes you have somebody who's really good at outreach, but they've never written a grant report before, and you can help them get there. What you're really looking for is the outreach for somebody, but you're judging that based off a grant report. I would also empower your mobilizers to become a powerful referral source and provide them with the resources to take the lead. The idea is that they are already doing this outreach and they are already this hub for their communities. And so all you need to do is give them the resources and let them go. And you're there if they have questions and they refer people to you, or at least that's the way that our model worked. I would also say to be willing to listen and make changes to resources and processes, and maybe have some check-ins occasionally with your mobilizers on what they're seeing or if they have any feedback. Some of the best feedback we've gotten from the program has been from mobilizers on what messaging was most effective among their communities, and that helped us adapt our outreach toolkit to reflect what was most effective. So thank you so much for having us today. If you'd like to reach out to us, these are our email addresses. It's just first name, period, last name @wisc.edu. And there will be a Q&A later. So for now, I'll just transition to the next presenter.
Good morning, everyone. Thanks for choosing to attend the session. I saw on the agenda that there are 4 concurrent sessions, so I'm so happy to see you here today. My name is Michelle Thomas, and I serve as program specialist within the Arlington County's Area Agency on Aging. And today I'm going to talk with you about outreach strategies that my team and I have integrated as a pilot program, 2 consecutive years that has been successful. Hopefully you'll obtain some ideas to replicate the program in your respective jurisdictions. In addition, I'd like to share an overview of the VICAP program, which is the program that I lead, offer some insight into stats for Arlington County at a glance, offer insight into health equity data, health equity tours, and the next steps before we transition to our last speaker and then open it up for Q&A. So who are we? The Arlington County VICAP program is housed under the State Health Insurance and Assistance Program, which some of you may be aware of. It's called the SHIP Network, which is in all 50 states, including Puerto Rico, Guam, the U.S. Virgin Islands, and also Washington, D.C. In Virginia, the program is known as VICAP. And the team, which consists of staff and volunteers, helps to teach and train individuals on all things related to Medicare. We also do an extensive job in helping to resolve billing issues, but more importantly, and as it relates to today's slide deck, we help to get people connected to benefit programs, in essence, and also helping to reduce their out-of-pocket health insurance costs and prescription drug costs. Arlington County, located in Arlington, Virginia, is right across the way from Washington, D.C. As of January 1st of this year, the estimated population was 240,000. The projected forecast of population for 2050 is 311,000. Approximately 41% of Arlington County's populations identify as people of color, and approximately 31% of Arlington County's households speak another language other than English. And I'll speak to more of that in a few minutes. I do want to also highlight that in 2022, the reported median household income was about $138,000, $37,000 versus the per capita income at $112,000 per year. I do want to offer some stats because our program works with individuals that are 60 years of age and older who have Medicare, but then we also serve on the other side individuals under the age of 60 with an intellectual or developmental disability. But specifically speaking to the demographics of 60 and over, I do want to spotlight that the Arlington Area Agency on Aging served a higher percentage of individuals that are female within the federal poverty level. And I'll speak to more of the federal poverty level in just a few minutes. There are higher concentration of individuals at 60% who live alone that the Arlington Area Agency on Aging serves. 23% speak other languages other than English. And then the stats go on. So 45% report being white versus 10% Asian, 34% African American, and then 18% as Hispanic. When it comes to VICAP's initiative, which is the program that I lead, we were able to go into the community, provide boots on the ground, go into where people are to help make a difference. The outreach strategy consisted of targeting higher concentrations of underserved communities. So our colleagues from Wisconsin talked about targeting key zip codes, and that's the same thing we did in Arlington County. There are a series of about 3 or 4 key zip codes within Arlington County that have higher concentrations of individuals who are minorities, low-income older adults, persons with disabilities, and then individuals whose primary language is not English. And when we were attending different outreach sessions, we helped to enroll people in different benefit programs to, in essence, help to reduce their healthcare costs. We provided cultural and linguistic services in Amharic, Mongolian, Spanish, Vietnamese, Korean, and many others using the telephone and in-person interpretation services. So while I know that, Arlington County is extremely diverse, if you look at other areas across the state of Virginia, let alone the country, there may not be that level of diversity, but there's still opportunity wherever you are to identify individuals who are of lower income or individuals with disabilities to be able to replicate a related strategy. So I do want to spotlight the sites that we were able to specifically target. While this is not all encompassing, this is a specific sector of who we were able to provide the most services to. So during the 2022 and 2023 pilot programs, we were able to provide services and resources to individuals at senior centers, independent living facilities, affordable living residences, a local food bank, and also faith communities. As we consider the work that we've done in 2022, we were able to serve 36% of individuals whose income was at or below 150% of the federal poverty level. In that same year, we served 28% of clients whose primary language was not English. And we specifically targeted groups who spoke Korean, Spanish, and Vietnamese. As we consider the Health and Human Services Poverty Guidelines in 2022, it was $20,000. And then the following year, we were able to extend and serve more than the year prior. So more than 10% of individuals were served in 2023 at 49%. And those individuals reported income at 150% below the federal poverty level. So if you look at the HHS guidelines from 2022 to 2023, there was an increase of less than $2,000, which is really low. In 2023, we also served 30% of clients whose primary language was not English. So there was an increase. And then in that year, we were able to expand our reach a little bit more and target individuals whose primary language was Amharic and also Mongolian. Now, as it pertains to outcomes, I do want to call out that our team served reached more than 1,100 individuals during the open enrollment period. So for those who are aware, the Medicare's open enrollment period is a 7-week period each year. So these stats highlight the work that we've done in our program over a 14-week period. So out of the clients that we reached 600 individuals. There were 526 that attended our presentations. And then within the 14-week period, we were able to save individuals a totality of $220,000 due to the enrollment in prescription drug plans, Medicaid, patient assistance programs, and prescription drug coupons. This is a photo of one of the sites. We were at a HUD site in Arlington County. And as we look at conclusion and next steps, we will, of course, continue conducting the health equity tours, expanding and going to sites that we haven't been to. We'll also utilize the data that CMS offers and, of course, the National Council on Aging to be able to expand our reach and obtain some data that can help us make more informed decisions and continue collaborating with the Commission on Aging. Arlington County has a advisor group and a volunteer-based group called the Commission on Aging and the Northern Virginia Regional Commission that helps to advocate for persons who are underserved and who cannot make decisions for themselves. Here's a snapshot. I do want to, of course, recognize my team on the left. And then at one of the HUD sites, I worked very closely with this older adult who's was 74 at the time. She unfortunately has now transitioned, but through the work that I did with her, we were able to save her $5,000. And here's my information. If you want to get in touch with me, you can contact Tom 2 at arlingtonva.us. Thank you.
Good morning, everybody. That was an introduction of myself in my traditional language. My name is Kateri Chino. I'm from the Pueblo of Acoma. I do work with Keres Community Health, which is a company of Keres Consulting. What we do is a lot of program outreach specific to Native American communities within the state of New Mexico. How's everybody this morning? We all right? Wrong way. It would be me to do that. So who we are, first of all, with the program that we have, we were funded through the New Mexico Department of Health, specifically to address the vaccine initiatives from the New Mexico Department of Health with the Native American community. So in working with Native American communities, we had to understand who we were, who the Pueblo was, what the context was in the state of New Mexico. So New Mexico has 22 Native American communities, 19 Pueblo populations, 2 Apache nations, and the Navajo Nation. For the purposes of our project, we work specifically with the Apache tribes and with the Pueblo communities. We have northern New Mexico Pueblo communities and we have southern New Mexico Pueblo communities. We have mountains, we have valleys, we have deserts, we have communities that outlie the riverbeds. So understanding the rural areas, the complexities of New Mexico environmental landscape definitely plays a role in how we help our communities and what challenges and barriers they're facing. And again, we come from the Anasazi people. We had to also understand that they're hunters, they're gatherers, they're farmers, and that there is strong family ties. So again, we're talking about connection to land, to people, to knowledge. I briefly spoke about interpretation of the environment, the environmental landscape. Being in such rural areas, it does impact the services that the Pueblo and Native American communities have. Understanding the importance of well-being and the way they think, Native American and the Pueblo people, in working with each one of them, they think from the outside in. So when they're praying for land and animals, they're praying for country, they're praying for leaders and the community, then their community leaders, their family, their extended family, their core family, their immediate family, and then their self. Okay. So when we're thinking about program outreach, we have to kind of think in terms of bigger to self. And that was a big concept for us. And then knowing their traditional knowledge that they have, their strength, their resiliency. Again, they go back to using land and animals and understanding that there is always a sense of hope with the Native American community. No matter how sliver it is, there is always a sense of hope. Hope that things are going to get better, or hope that something will change. You know, they're constantly praying for something. Keres Community Health works with the indigenous social determinants of health. So we're taking into account utilizing indigenous knowledge. When we speak of indigenous knowledge, this is when we're going out into the community, boots on the ground work, and we're speaking with the community themselves. We're getting information. We're talking about their health and well-being. We're talking about their origin stories. We're listening to their kinship lines. You don't just go out and like, hey, this is how it's going to be. You have to account for the time that they want to discuss their history, the time that they want to discuss their land, or somebody went hunting and we fed the community. So understanding their cultural beings, like their traditional dances that they have, who else they pray to, who else they definitely take into account as part of their healing process. We're talking about sovereignty. Each of these pueblos that we've worked with and tribal governments have their own form of tribal government. It's not a copy and paste. They have their own laws. They have their own design and implementation of programs. So even though we work like with the New Mexico Department of Health as a private company to go in and work with the indigenous communities, we have to also understand that they're creating and designing their own programs. So we have to prepare for that. Structural and systemic factors. We're taking into account the historical trauma. And by that, like, we're way back to smallpox, how that wiped out the communities, how they had to rebuild, retrust, re-identify themselves. And New Mexico is now accounting for all of these systemic factors and social factors when working with the Native American population. So that has been a big win for the Pueblo people in New Mexico. We went out and we spoke with them about the COVID-19 pandemic. Again, it was about the challenges that they faced, the barriers they faced. They had immediate Pueblo shutdowns. Like, some of these Pueblos closed the gates to their community, locked them up, and were like, there's nobody in, there's nobody out. You had to have your census ID number or identification, proof of residency that you were allowed to be in the community. Same thing, it was patrolling within their communities. They had law enforcement patrolling within their communities, making sure that you were within your home, all just to ensure safety within the communities. They definitely during that time had a loss of identity, a loss of trust, a loss of closeness, because Native American communities are really family oriented, family strong, community strong. So when COVID happened, not having that sense of identity to tie next to somebody right close was a big loss for them. We also spoke about historical trauma. Again, that comes back to the smallpox, the lack of trust, and the need to protect themselves. This was a trend that was spoken over and over among the communities, was a need to protect ourselves, to protect our community, to protect our people. We spoke about past, current, and future practices on what they learned, what wasn't working for them at the time, what is current, what programs have come to surface that they found successful. And in all of that, the elders came to the top. Elders were initially hesitant and they were like, again, historical trauma. I'm not sure if I want to do that. But as they saw the COVID deaths rise, then they stepped forward and were of the mindset that, hey, who am I going to pass stuff on to? Like, I'm the only source of information for our culture that I need to ensure my family knows this. So yes, sign me up for the vaccination. Keres Community Health looked at the broad social determinants of health as far as our approach to best practices. When, in general, that comes down to food, to shelter, to survival. We took into account unique indigenous social determinants of health. And this is where we tied in a lot of the cultural components, like the cultural, the being, traditional foods, the families, the ties, the land, the animals, leadership. And then we also address shared indigenous social determinants of health, where we combine the public view with our traditional view and how we can move forward. So for example, when we had food drives, we're speaking about rural communities that have the nearest town is about 65 miles away. We have transportation issues. So we had to identify a plan that we're able to go pick up the food at the city location and bring that back to communities and do house deliveries or do a central location where they can have a food drive and pick up whatever was available for the community. The community during that time pulls through, like at times of disparities or pandemics, the community definitely pulls through and fights. They look out for one another. You know, they make sure, hey, our neighbor didn't get their food package because they've been having transportation issues. I'll go get it for them and put it on their door. Like they really are kinship close like that way. When we're talking about family, it's not just my brother or my sister. It's my second and third cousin on the same line who I consider my brothers and sisters. So understanding that context definitely helped us when we were working with these different pueblos and communities. Again, we were working to increase vaccine confidence. We provided culturally tailored education material. So we had capability sheets that identified all the important COVID information, the rates, the updates, but we provided them also in their language. One of the big things among Pueblo is like our people, like let's protect our people, let's help our people, let's safeguard our people, let's look out for our children. So utilizing capability sheets in their language that they're going to understand was a direction that we took. Again, we included Pueblo language, and then we did address, again, rural accessibility and care. The communities that we worked with, probably about 2 or 3 of them maybe had a clinic within their community. For the rest, it was over an hour's drive, access to services. So they have to make sure they're utilizing their community health representatives or their community health workers to transport if they need. Then they run into scheduling issues, scheduling conflicts, more people to transport than we have available resources. So we were trying to find ways that we're able to limit those barriers that they have for them. Taking into account the reservation and environmental factors, their homes are not glitz and glory, right? We're dealing with water issues. We're dealing with roofs that are probably leaking. We're dealing with homes that are 40 plus years old that have accessibility issues, smaller doorways, stairs instead of ramps. So understanding those level of barriers was key in being able to identify needs. Working with trusted messengers. When we're talking about trusted messengers, we're talking about their leadership. We're talking about their cultural leaders, not just their governors and lieutenants, but their cultural leaders, their war chiefs, their leaders within their kivas. And when we go out and build those bridges and have those kind of conversations, the hard conversations, they begin to trust you. They begin to establish rapport and relationships. So now as a trusted messengers ourselves, we're able to bring in another agency and be the bridge and tell them, reassure them, yes, this agency is a good person to work with. They are a good team to work with. They've bought into our program. We're in the door. So now we're able to bring in additional resources for them. We definitely take into account culture and identity. In the Native American populations, that is all it is. Culture and identity. Accepting their culture, accepting their identity, understanding who they are, understanding that there is going to be some resistance, accepting the fact that sometimes you are going to be met with, nope, this is your fault. We've tried to run this program before and it didn't work. We don't want to do it again, and shut the door. Right? Be willing to go back and re-engage and accept that, yes, at some point somebody did make a mistake, faulted you guys, and we're not here to do that. We definitely want to work with you. How do we get there? Oh, no. That would be me. Is there a power button? Oh, yeah. Good thing that was said. So again, my name is Kateri Chino. I'm the program manager for Keres Community Health. We are based out of New Mexico, and thank you very much for your time. I hope you guys have learned a lot.
So great. I've learned so much. So I'm going to invite our panelists up and we're going to have some Q&A. I have some questions, but I will let you guys go first. So if you have a question, feel free to just raise your hand. You definitely come up to Q&A.
Maybe we can just go straight
to where we were at.
Sure.
Okay, well, I will kick it off while everybody musters up some courage or some questions. I feel like you all are y'all comfortable always. Okay.
Challenge type.
I know. I feel you. So I feel like all three of y'all hit on the same type of message, which is number one, about building trust with these communities and also listening to them. So would love to hear if somebody wants to give a prime example, maybe with the patient or just a story you heard about the value in building that trust, or maybe a learning lesson of we really had to listen to our stakeholders and who we're trying to, impact and take in that feedback. Because I feel like you just hit on that, but everybody talks about building trusted messengers, working with people from the community to help the community. So we'll love to kind of dig into that more, because I feel like that's really a fundamental piece when you talk about outreach work.
I guess I'll go ahead and start this off. So, working with our Pueblo communities, the leadership, the governors within the communities are always quick to stop and let me figure out what you are, who you are all about first before you can come in and speak to us. And we have our funding sources that are like, hey, we need to see something. We need to see some work that you guys are doing, and trying to bridge that gap. We have the push right here. And then we have the pull back from the tribal community. So that's one of the concepts that we had to really enforce with our funding sources and identify in our own program initiatives, was that we got to have discussion on barriers and challenges that we're facing on a monthly basis. So that way you guys understand that work is being done. We are going out there, but this is what we are actually facing on boots on the ground work. Bridging the gap with the tribal communities, it does take sometimes about 3, 4, 5 times in some instances, going out there, driving the 2.5 hours for some cases, as far as location to where our base office is to where tribal communities are. It is a 2.5 hour drive. So making those efforts to, I will go see you at your location. I will make the drive. I will put in the time, like even if it's just for 5 minutes. And if it's on a repetitive basis, well, then I guess I'll be out there multiple times meeting and speaking with you. But as you get there and you start speaking with them, and I'm from the Pueblo of Acoma, but I've also grew up outside the Pueblo of Acoma. So I've been a city girl too. And having to come back, you're just really gung-ho to work and help your people. And that I tended to forget, like, well, I got to listen before I fully engage. So that is a huge component, is listening. and understanding, having a sense of empathy in working with the population.
I'd like to speak to the relationships with the churches. Arlington County's program that I lead is housed within Arlington County government. And typically, when you consider churches and government, a lot of times people think that they're two separate entities. And while they are, there's still some overlap. And as we consider the relationships that we have been able to build with the local churches in Arlington County, I must say there has been a lot of headway, because a church is one place that you're able to reach many people, regardless of race, age, gender, sexual orientation, and things of that nature, language, and so much more. And so, when she talks about building, those relationships, is key to be able to, number one, listen, number two, be able to talk about what you can offer from, what we were able to offer to the constituents, and the parishioners and others who attended the churches, and then continue to, bridge and form the relationship by inviting them to opportunities and engagement events that we had within the county, but then also attending and showing up and being a reliable source and resource to the individuals who attended the churches as well. So that sometimes means evening outreach engagement opportunities. That sometimes means weekend engagement opportunities, but it's really being that reliable source and voice for them to feel comfortable to come to us. And then that's where we're able to leverage that. And I know during the height of COVID, not only did they invite us to participate in outreach events that they had, but we were also able to work with public health and have boots on the ground opportunities for people to get vaccinated. We were able to disseminate LGBT resources. We were able to talk to people about the importance of dental work, because, some of you may know Medicare, or especially original Medicare, does not cover that. So we were able to, leverage those relationships and expand them in a way to help reach the underserved communities.
Thank you for that. So this is a question for our covering Wisconsin folks. What would you see the value in working with some of these smaller community-based organizations? Just because they're already, like you said, on the ground, they kind of know the work. But can you just speak more to kind of that partnership? Maybe not necessarily just this grant participation, but other ways that y'all work with community-based organizations.
Sure. What was the start of that question? What did we see being the value?
Yeah.
Okay. Well, they're kind of thin and nimble, They're they have such flexibility with the work that they do. And I'm trying to think of something specific about them being smaller that makes them significant, but I think it's the work that they do and that they happen to be small. They do significant work in their communities one way or another. And we built relationships with them because there was some intersection with access to healthcare and health coverage, and we just moved. And I'm seeing a bunch of hands.
I know. And hands back here in the back, and then we'll go right here. Then we'll go right here, and then we'll go right here. And then that's it. See, we can see it good 2 times apparently. And I didn't even look at y'all, so y'all might have had y'all's hand up. I said I had my questions lined up.
Hello, everyone. My name is Christina Madison. I live in Las Vegas, Nevada. And so my question/comment is around communications, because each individual groups that you guys spoke to are very culturally different groups. And so I wanted to know what you felt was the best form of communication to get the word out about your services, and whether or not you employed social media, and what forms of social media you may have used, because I know different groups respond differently to different forms of social media. Just for example, I did some work at the border in Laredo, and it seemed to be very helpful to use things like Facebook groups, which was very different from other areas where like our Indigenous folks, it may just be flyers or word of mouth, or with our community groups with faith-based organizations. I'm just curious, what did you feel was the best form of communication to get the word out about your services? And with that form of communication, do you feel like there's ways for those of us in the audience to amplify messaging?
I can jump into that. We want to jump. Okay.
We can both.
Yeah, we can both do it. So I think since we're a statewide program, it really depends on the community. For the rural areas, it's definitely in person, word of mouth, direct introductions. She's cool. Not so much social media, but for our urban areas, social media has been pretty effective. We haven't done anything quite like Facebook groups, but we do have the Facebook and the Instagram. And part of what our mobilizers do is help share posts and help amplify the message and share materials from our promotions toolkit. And we kind of let them take the lead on that and give us feedback on what's effective in their communities. And then we reciprocate that.
Yeah, and I was just also going to say, in addition to the social media aspect, that we use both urban and rural. In the urban setting, what we've done is while we cannot utilize TikTok per se, our community-based organizations can. So they'll take the message, and we try to keep that message very consistent, very easy to understand for all groups. We diversify it across languages like Hmong, Spanish, and English. The same message, the same consistency, just to speaking to their language, their preferred language. We also find, or I also find, that working with those small community-based organizations, when they're in specific communities, say for instance, it's a community that they most serve the Rohingya community or Vietnamese, they always make sure that they have someone that is language proficient to be able to help folks to understand how to utilize our services in their preferred languages. They also have a pulse on the community, so they know what the community needs, because they're the ones that are providing those other resources like food for food insecurities, housing, and they're trusted already in the community. So if they're adding the layer of the importance of having health insurance coverage or needing assistance, this is an organization that you can go to that's going to help you do that for free. These are the trusted organizations. They have the familiarity of their communities, and they help us with the reaching those folks that we normally wouldn't be able to reach with that message.
And that's the beauty of leveraging relationships within the organizations. Arlington County is such an urban area. It's like 15 minutes across the way from Washington, D.C. However, we, in addition to using online tools and resources, we've had to do the boots on the ground approach, depending upon the population. And of course, you talk about language. We've had resources translated in a myriad of languages and had them distributed in libraries and other venues. And then I know one year, I even went so far as to work with another agency within Arlington County to have bus ads in the art buses translated into another language as well, because, the folks that we serve do ride the bus, right? So going into, different places like that to be able to reach individuals has been important. But then we work with younger folks who are caregivers. So they may have small children and they may be taking care of a parent or an older person as well. So, reaching them is a different target audience. So it's really building upon an effective communication strategy, always reassessing the communication strategy because it may change. And so, reaching a 40 plus or 50 plus year old through social media, Facebook, having radio interviews, podcasts, and things like that have also been an integration into our communication strategy in Arlington County.
As far as working with the Native American population, so when you go to tribal communities, they have marquee boards at the very front of their communities or by their schools or by their tribal administration buildings. So a lot of their messages are delivered there. There is a lot of boots on the ground, flyers, handouts, taking them to the schools so that they can be distributed through their children. And notes is, again, flyers that go home. We've also utilized our partner agencies as part of a coalition, that the Better Together coalition that we're a part of. We're able to work with Generation Justice, who is a radio communication. So that's how we're also able to get out our message. They have some radio time on Sundays that targets the Native American population. They play Native American music. They have interviews specific to health disparities. So we're able to utilize that. We also utilize some form of social media for the younger population that gets around. And again, it's who we're targeting, what we're trying to target about is how we're delivering our message, utilizing our tribal leaders when they're in the kivas to deliver the message as well.
Hi, I'm Clark Palmer, Communications Director, North Carolina Medicaid. I think you answered a lot of the questions I had around just your communication strategy and what you've used. But I'm curious to know, were there any unique things that you used in your toolkit and community? One of the things that we're using in North Carolina is just church fans. We put information on the church fan. It's getting hot. We're a festival state. So when people are outside, they can have these fans and have information that's there. Is there anything, again, unique that you all used in your toolkits?
Language access, making sure that everything's in both English and Spanish, and getting as much. We have a large Hmong population in Wisconsin, so we also try to get as much into Hmong as we can. Another thought is having a diverse representation of many different communities that can be found throughout Wisconsin in the different imagery. And we do focus groups for what messaging is the most effective among different communities, and reusing. Maybe I shouldn't say reusing. Finding which messaging was more effective in previous years and what had the most hits, and then capitalizing on that.
Was there any specific materials that you used? I know there was fact sheets and things like that, but if there was anything else that you added to the toolkit to get that message out.
Yeah, our most popular outreach item is like a postcard that's double-sided. And on one side, it has sort of like the ad that says, need health insurance or something to that effect. And on the back, it has bullets for things that we can help with. And it has a QR code to our web chat and our website and our contact information.
And it says free.
And, yeah.
There's a question right here, and then we'll.
My name is Amit Jindal. No points on guessing where I'm from. My accent would have given it away. I'm from Tennessee. Okay, so you first of all, great work, very inspiring work you are doing in the community. My question: a lot of public funding involved. Is there a role for private sector in what you do?
Yes.
And if there is, I would like to hear more about that.
Yes. So, again, Keres Community Health is a private agency. So we are definitely not for profit. But we do expand to charitable work. We just have to find, working with Native American communities, for them to be able to buy into our company and trust our company and want to build that way.
And for Arlington County government, the way that it's structured, I mean, we do definitely work with partners in the community across the board. We wouldn't be able to do the work that we do without them. So we look at them as our champions because there's a reach that you have that we don't have, and vice versa. And that's kind of the beauty of working with a multitude of people in the community. So, I'd be open to talking with you afterwards to learn more about what you do and a possible connection. Thank you.
Yeah, and I just say the private sector can really be helpful in providing resources to community-based organizations to help address those social drivers. So transportation, food insecurity, housing, there's plenty of ways that you could help provide grants to the folks that are doing the work to help support for those things that don't have funding. So unfortunately, we are out of time. They have held up all the signs for us. We'd love for you to come up and ask your question. But thank you guys so much, and let's give it up for our